Hey everyone, you're listening to IM Bites, short evidence-based conversations for internal medicine residents. Each episode, we take one clinical question, walk through the data, and figure out what to do tomorrow morning during rounds. Less than 15 minutes, one question, real evidence. Quick reminder before we start, there's a quick survey linked in the show notes. Your feedback shapes what we cover next, so please take a minute to fill it out. My name is Luke, and today on IM Bites, we will be discussing a pulmonology case in clinic. Before we get into episode 1, I want to spend a couple minutes with the person who started this whole thing. Moemen, you ready?
Hey, Luke. Yeah, I am ready.
All right. For people hearing about this podcast for the first time, what is IM Bites?
Well, IM Bites is a short evidence-based podcast for internal medicine residents. Every episode is 15 minutes or less, focused on one paper or one guideline. Two hosts, a resident with either a senior resident or faculty co-host, walking through what the evidence actually says and what it means at the bedside.
And why is that helpful? Aren't there a lot of medical podcasts out there already?
Yeah, there are actually. A lot of them are great. The honest answer is most of them are too long. For example, Curbsiders is great, Core IM is great, but 90 minutes is a luxury most residents don't have on a week inpatient. The idea here was, what if you could get the high-yield version of a recent trial in the same time it takes to drive home from the hospital?
In the format, why a conversation? Why not a narrator going through a paper?
Because that's not how medicine actually gets taught on wards. You learn from senior residents quizzing you, attendings pushing back, a co-residents asking the dumb question that turns out to be the right question. We wanted the podcast to feel like that, a workroom conversation, not a lecture.
Got it. And who's the audience?
Mostly, IM residents, PGY1 through PGY3, but really anyone who wants a quick, honest take on whether a new paper should change practice. We're rotating through cardiology, pulmonary, GI, with more committees coming as the project grows.
Awesome. Anything else listeners should know before we get into episode 1?
Just give us feedback. There's a quick survey in the show notes. The whole project is built on feedback from residents about what's actually useful. So fill it out. Tell us what to do differently, what topics to cover next.
Perfect. Let's get into it.
Let's do it.
Welcome back to IM Bites, everybody. My name is Lukas Akes. I am a second-year internal medicine resident at The Ohio State University.
And hi, everyone. This is Jesse Pullen. I'm a first-year EMIM resident at The Ohio State University.
Today's episode will take place in the outpatient pulmonology clinic.
All right. So, Dr. Akes, that last patient, the new sarcoidosis?
Yeah, the gentleman with diabetes.
Right. Biopsy-proven pulmonary sarcoidosis. His FVC is trending down with a meaningful drop over the last year. He's been coughing, dyspneic on exertion. He clearly meets an indication to treat.
Yeah, and this gentleman's comorbidities are the thing, right?
Yeah, that's where I'm getting stuck. His A1C is over 9. His diabetes is just not great in general. He's got osteoporosis on his last DEXA. So I want to treat his sarcoidosis, but 6 months of prednisone is really going to wreck his glucose and his bones.
Yeah, classic situation of the textbook says one thing and patient says another, right?
Exactly. So my question is, could we start him on a different agent? Instead of the prednisone, maybe something like methotrexate?
Yeah, and skipping the prednisone entirely, that's a good question. And 2 years ago, I would have probably said no, methotrexate is second line. But there's a paper that recently came out in the New England Journal of Medicine in May that really changes how we should think about this. PREDMETH.
Okay. Prednisone, methotrexate?
Yeah. Tell me what you already know about methotrexate.
Well, I guess I know it's second line. We add it when patients can't tolerate steroids or relapse or when we need a steroid sparer for long-term therapy. It's slower in onset and has a different side effect profile.
Yeah, exactly. And I think, an important thing to know about that is that's mostly based off retrospective data and expert consensus. There's never actually been a randomized head-to-head trial that compares prednisone versus methotrexate as first-line therapy. And this is exciting because PREDMETH is the first.
Okay. I'm curious to learn more. Tell me about the study.
Yeah, let's talk about the study a little bit more. It was a Dutch trial. It included 17 hospitals, open label, randomized, non-inferiority, but the statistician was blinded, which matters for the analysis. Overall, had 138 treatment-naive adults with pulmonary sarcoidosis who actually needed treatment.
That's a pretty good size trial. Tell me though, how'd they define who actually needed treatment?
Yeah, they defined it by the standard ERS treatment criteria. This includes symptomatic patients with parenchymal disease on imaging, plus either reduced lung function, a low FVC or low DLCO, or a meaningful decline in either over the past year. So patients with something real to treat, not these borderline cases.
Sure. So something substantial.
Exactly.
ERS, though, that's the European Respiratory Society. What do we use here in the US?
Yeah, surprisingly, it's the same document. ERS in 2021 is the current sarcoidosis treatment guideline internationally, including the US. ATS hasn't put out a separate treatment guideline since the joint ATS-ERS statement back in 99. So a lot of American pulmonologists still reference the ERS document in practice. And interestingly enough, the panel that wrote it included USers.
Okay. So we love to see the US and
Love to see
Europe,
it. Love to see it.
collaborating on this issue. That's amazing. What else should I know?
Yeah, so I think big things. Exclusions were exactly what you'd expect. These patients that had, history of prior immunosuppressants, contraindications to drugs, as well as pregnancy.
Okay. That seems pretty standard. What about their randomization process?
Yeah, randomization. It was 1-to-1 for 24 weeks on the prednisone arm. They started at 40 milligrams a day and tapered by 10 to week 16. And then the methotrexate arm was 15 milligrams oral once a week to start. And then it was titrated up to 25 milligrams weekly.
Sure. I can follow that dosing regimen.
Mhm.
Tell me more about, primary endpoint.
Yeah, so what they looked at was the mean change from baseline in percent predicted FVC at 24 weeks.
Okay. Yeah. So 6 months on therapy. What did they find for their results?
Yeah, prednisone group improved by about 6.8 percentage points, and in the methotrexate group, about 6.1.
That sounds pretty identical.
Yeah, the adjusted difference was tiny. I would say about a single point. So well within the pre-specified non-inferiority margin. So all this to say, methotrexate was non-inferior.
Okay. So remind me, though, we have to check this both ways, modified intention to treat and per protocol?
They did. And just a quick refresher for everybody out there. The modified intention to treat analyzes patients in the group they were randomized to, and this is regardless of crossover compliance. So really, the closest to the real world situation. The per protocol only includes patients who actually got the assigned treatment as planned, which is a more pure comparison. And really, in a non-inferiority trial, you want both of these to agree because the modified intention to treat can artificially favor non-inferiority if there's a lot of crossover.
Gotcha. So approximating the real world, these results can be translated to everyday practice.
Yeah, exactly.
All right. So, these results are pretty shocking. Where does prednisone still win?
Yeah, really the place it wins is speed. Most of the FVC gain in the prednisone group was already there by week 4, whereas the methotrexate group built more gradually. So if you've got someone, that's acutely symptomatic, really struggling to breathe, short of breath, that early bump still belongs to steroids.
Huh. Okay. Got it. What side effects do I need to be aware of?
Yeah, I think looking at both drugs, the prednisone side, things we expect, weight gain, insomnia, bone loss, increased appetite, the mood swings, whereas the methotrexate side, a lot of the GI side effects we expect, nausea, fatigue, abdominal pain, but interestingly enough, also the elevated LFTs that can happen with methotrexate.
Sure. So it's not that methotrexate is safer. It's just that methotrexate has different side effects.
Yeah, exactly. And I think something that was interesting was that most of the side effects with methotrexate were transient side effects. Typically, in these patients, they resolve during the trial or after a change in formulation, whether it went from oral to subcutaneous. So dose adjustments, right? Whereas in the prednisone group, fewer than half resolved by week 24. So still that burden with steroids.
Sure. So short-term gain for long-term maybe risks.
Yeah, exactly. Yeah, I think that's a good way to think about it.
Okay. For our patient, though, the one with diabetes and osteoporosis, it seems like methotrexate could be pretty attractive for him.
Yeah, I completely agree. And I think, with prednisone, it's going to spike his glucose. It's going to accelerate his bone loss, which we know is already present based off of his last DEXA. It's going to mess with his sleep, going to make him gain some weight. And I think, we don't want to forget that methotrexate is going to have its own issues, but it won't worsen his diabetes or osteoporosis.
Sure. Before I get too hyped and before we take this to prime time, what should I be careful about with this paper?
Yeah, really 3 big things. The first being the open label for patients and physicians with no placebo. The blinded statistician did help with this case, but it doesn't fully neutralize those expectation effects, especially, when it comes to patient-reported outcomes. The second thing, this trial was designed before the most recent ERS sarcoidosis guidelines. So the doses that they used aren't quite what current guidelines recommend. Third thing, of course, is the modest sample size, the single country where the study was done. And very important is the population of patients, as they were mostly white European.
Okay, so some asterisks to be aware of.
Yeah, definitely.
What didn't PREDMETH settle?
I think in my mind, there are also three big questions with this study. First is the durability after 24 weeks. We know that sarcoidosis is a chronic multi-year disease. So we don't know whether methotrexate first patients, did well at 1 year, 2 years, or off therapy. I think second is, what about these patients that have been on immunosuppressants in the past? They were excluded from this trial, so we're missing that information. I think third is the generalizability. We know that sarcoidosis is more common, more severe, and does behave differently in Black patients in the US, which were not well represented in the Dutch study. So I think those three things are the things that PREDMETH did not answer.
Okay. So gave us some really great data, but we still have some lasting questions.
Yeah, still some questions, still areas for future opportunities.
Okay. Well, getting back to our patient, for him, I'd like to lay out the options. Prednisone, it's going to be faster. He's going to feel better in 2 to 3 weeks, but it comes at a cost. His diabetes control is probably going to worsen, and his bones are really going to feel the aches, so to speak. Methotrexate, it'll be slower to take effect, but, it's once a week. We do have to watch his LFTs, his blood counts, and for some other patients, we might have to talk about contraception counseling, and even alcohol cessation or cutting back.
Yeah, and what I think is beautiful here is this represents a real shift. For the first time, we have an evidence-based first-line option, which is methotrexate. So I think that's the bigger story with this patient and his comorbidities that we've been talking about.
Yeah. So it seems like we've got the data now to let patients pick what option works best for them.
Yeah, we are shared decision-making advocates.
We love shared decision.
Love it.
All right. Well, let me get back to him and outline the options.
And that's it for this one. 3 things to hold on from PREDMETH. First thing, methotrexate is non-inferior to prednisone as first-line therapy for pulmonary sarcoidosis. Second thing, side effect profiles are different, which makes methotrexate especially worth considering for patients where steroid harms are amplified, this being patients with diabetes, osteoporosis, pre-existing mood disorders, and obesity. Third thing, speed advantage still belongs to prednisone for the acutely symptomatic patient. And lastly, we do have a survey link in the show notes. This takes roughly 90 seconds and helps us improve this podcast. See you for the next episode. Hey there, listeners. Well, I Bites is an evidence-based podcast by residents for residents. The views and opinions expressed during these conversations are those of the individual speakers and do not necessarily reflect the views of the Ohio State University, other affiliated organizations, sponsors, or the podcast producers.